All right, welcome everybody to the May 2024 edition of the Medicaid Client Voice Council. My name is Jason Peterson, Deputy Chief of Community Engagement for DHS. We have a number of our Medicaid Client Voice Council members watching via Zoom, and so a reminder to them, I've got my phone with me. If you have any questions for our presenters or have any questions in the open question period, text them to me, and I'll do my best to notice and include them so that you can get answers to your questions. Thank you to the members who are here. I did hear from a lot of members even this morning who have sick kiddos, who have car issues, who have other obligations that couldn't be here. So had a lot of reasons for absences, but for those of you who made the trek to be here, we really appreciate your presence, and I know DHS leadership is eager to hear your questions and hear your comments about some of the presentations that are going to be made here today. Secretary Putnam had an obligation. She could not join us here today. She sends along her best wishes and hopes that we have a productive council without her. We have a number of topics we're going to hit on today. Hopefully you got the emails from me and were able to review some of the information I sent, and better prepare yourself to ask questions. I do have one announcement off the top. Etandra McClure has resigned from the council. She couldn't be here today. She's missed a couple meetings. She was feeling bad that she couldn't meet her obligations for attendance wise, and so she thought it would be best to just resign from the council. So I share that with you. We haven't decided if we'll replace her or if we'll just wait until the calendar year ends and replace her with a new member as we would otherwise. So the roadmap to a healthier Arkansas, ARP funding, that's what we're going to start with today. It's the first item on the agenda. Oh, let me take a moment because we do have Brandy here, although Kristen is not here, Brandy's here. So I like to offer our chairperson and vice chairperson a chance to say a few words before we start. So Brandy, if you'd like, I could bring you the microphone. Do you have anything you'd like to say? No? All right, you're going to forego that opportunity. So let's dive into our agenda. ARP funding, the roadmap to a healthier Arkansas. We're going to build out the care continuum for vulnerable populations over the next 5 years at DHS, utilizing American Rescue Plan funds that will expand, enhance, and strengthen home and community-based services. So we've got some information on that for you. Maybe you have some questions or some comments about that. So we have with us today Melissa Weatherton, Director of Medicaid Specialty Populations, and Paula Stone, Director of the Office of Substance Abuse and Mental Health. So if you ladies would like to come up, they have a slideshow presentation. And that will take up the first hour or first, at least part of our meeting before we have lunch. So got a microphone for each of you. Thank you very much.
So this, is it on? Okay. So this is a small portion of our entire roadmap. So do you want to, you'll talk about the roadmap at the end.
We can start there.
Yeah, you want to start there? Yeah, start with the roadmap.
Yeah. All right. So what we've been working on for the last, I would say, several months is we've received a bunch of different types of American Rescue Plan Act funding. And I've talked to you guys about this before preliminarily, but now we've fleshed out our initiatives. So we issued what we're calling a roadmap to a healthier Arkansas about 2 weeks ago. I have a one-pager here that has a QR code that I'll set in the front. So if you want to get over that QR code, it'll take you right to the link. And there's also a link to where it is on our website. So what you'll find on that website is the roadmap that goes through the 20 some odd initiatives that we are building with American Rescue Plan dollars from the federal government. It'll take you to strategic plans for the Division of Developmental Disabilities, for Paula's division, her plan for the next several years of what she's focused on for behavioral health and substance use disorder. And it'll also take you to the aging plan for what we plan to do in the aging space out in the community to support people who are aging and elderly. So those 3 strategic plans are there, as well as the roadmap, as well as also on our website. Right now, we have open grant opportunities for many of our providers. So we have posted $20 million of grants. It posted on May the 3rd. We had a big kickoff event actually here I finally paid him for letting us use the space a minute ago. So I owed him money. But we had a kickoff event here on May the 3rd. We unveiled our roadmap and our grant opportunities, and they're open for providers to apply up until June the 3rd. And very quickly, what they are things that we could not spend any other funding source on. So it's money that we had to go ask the governor for approval. It was money that came straight to the state of Arkansas, and she had the authority to approve or deny our request, and luckily she approved. So we received $30 million from the governor's American Rescue Plan funding bucket. $10 million of it is to pilot and build statewide crisis. So when we say statewide crisis, we mean like other states have done, and we're actually going to Arizona in about 2 weeks. A lot of us in this room, this man's going with us, it's going to be fun, to look at how they've built out their crisis model and how crisis stabilization units fit into that model, how they have a uniform system, how calls get brought into it, and how they're triaged out to mobile crisis teams. So the whole point is to build something that responds immediately and where people are. Right? So to quit bringing people into emergency rooms or arresting people or sending them to places they don't necessarily need to go, nor do they receive the right health care when they get there. So $10 million will be put in what we call a request for proposal, which is a state term for how we legally do contracting in this state. So we put out essentially what we're asking for, and then vendors can come bid on it. So the pilot will happen in 4 areas of the state, and we plan on getting that contract out for bidders by the end of this year. So what's another reason we're going to Arizona is to pick their brain a little bit about how they did their contract. Make sure we're getting everything we want with the money. The remaining, out of the 30, 10 for that, the remaining 20 million is what's open right now on our website in terms of grant applications for providers. So what we're allowing providers to bid on are, we have asked for someone to come build or renovate us a community reintegration program, which is a 16-bed residential type facility for children that we want to get back out into the community.
Sorry.
Step in anytime here.
No, and these are all, this one's a Medicaid service. It's a current Medicaid paid service, and we haven't had a lot of uptake in that. We have one provider. We have another one that's opening in Pine Bluff in, I think, 2 weeks. But we've only had one in Fort Smith. So this is really that support to renovate a building, get that startup out there, because we've talked about this a lot in Medicaid Voice Council, which is we can change policies, we can reimburse for a service, but sometimes providers need that extra funding to really get that service up and running, because it's hard to get from zero to delivering a service, particularly when it's delivered in a 24/7 residential placement.
Absolutely. Mm-hmm. So in addition to needing desperately more community reintegration, which is why we're putting the money towards that project, we also know that we have a great need for inpatient substance abuse treatment for adolescents in the state. Right now, there is no inpatient substance abuse treatment. So part of the money is for a hospital to be able to come in and renovate a wing to do that service for us. So that is a grant opportunity for a hospital. There are 2 different grant opportunities for apartments. So housing is a huge issue in our state. And so we are focused on 2 very distinct populations. So one of the grants is for people with mental illness or substance use disorder that has undergone treatment, and they need somewhere to live, and they need some continuation of Medicaid services to get them out in the community. So one of the grants is for someone to come in and renovate or build apartments for that specific population. Second is for children who are aging out of DCFS or DYS custody. So those children who unfortunately have turned 18, cannot go back home for whatever reason, either chose not to be adopted or were not adopted, right? So to have somewhere for them to go, and for us to also provide Medicaid services in that apartment building or buildings to get them back on their feet, life skill kind of development. So we're looking at building out a new service for those apartments where essentially I think Paula's envisioning, driver's license, money management, training, employment opportunities.
Yeah, we've got services that you can provide, Medicaid providers can provide. One of them is called Life Skills Development. Another service is called Supported Employment, and another service is called Supported Housing. And so, you have to have a place to live to actually get supported housing, right, is really difficult. So having that place to live, and then we can deliver those services and help young people who have mental health conditions really learn how to budget, keep house, find a job. Really, this is to keep them from becoming to need to apply for Social Security disability, because sometimes that's what happens is when they age out of foster care, they apply for Social Security disability, and that's where they stay for the rest of their lives, because they need that income to promote and being able to pay for a place to live. And so really kind of trying to make sure that that's something that we can provide, and then they can start earning money and start getting used to paying for rent, and then kind of transition back out into the community and be fully supported.
We have a lot of we have a really good nonprofit organization that does this very, very well, that we are working with on some of this, right, to try to model what they do in their organization. We also have a grant opportunity open for what we call a therapeutic community, but this is a different therapeutic community. This is a therapeutic community specifically for people with intellectual and developmental disabilities. So although we have 13 therapeutic communities for adults with mental illness, that's a lot of times where people that leave our state hospital go live. We don't have any therapeutic community right now that will take clients with a diagnosis of intellectual disability, which means the only option for them is to usually go to either the Warren Human Development Center or the Boonville Human Development Center, which both provide excellent service and care, but there's wait list for each one of those facilities, and so we need other options in the community. So therapeutic community is a 16-bed type placement for adults, where they can go live there and receive the treatment they need for their behaviors as well as their intellectual disabilities. So that's very targeted in one of our grants. And then the last one is money for current or willing, maybe that's another way to put it, substance use disorder providers for adults that already have that book of business going, and they need help like renovating their kitchen or adding on space. This one has an asterisk on it. If you get on that grant application, the reason it has an asterisk is because currently Medicaid cannot pay for adult inpatient substance abuse treatment, but Paula has filed.
Yeah, it says with CMS, so we've asked CMS for a waiver. So we can't pay, no state Medicaid can pay for treatment in what's called an institution for mental disease. This is a very old law, but it's still there. And so an institution of mental disease is anything above 16 beds. Its primary purpose is to treat people for a mental health or substance use disorder condition. And then CMS came back and said, okay, we'll waive that and people can be treated for a short time, but there's all of these rules around what you have to do for those waivers. So we've applied for a waiver as part of our, we've applied for a reentry waiver for people that are leaving prison or jail. And as part of that, we've done an IMD for mental health disorders and for substance use disorders. So we've got a lot of work because those substance use disorder providers have never enrolled in Medicaid because they couldn't get reimbursed. Now they do get reimbursed through the qualified health plans currently. So for our Medicaid expansion population, they are paying for those services. We've just not been able to have Medicaid fee-for-service or the passes pay for those services. So we're going to have a lot of work to do to get those providers trained and ready to roll. But this will start that process of getting facilities in good shape. And then we're coming in with some other funding from another grant that we can talk about at another time to try to get providers ready.
So is that also, whenever you're thinking about that model, is it going to be easier for facilities to apply and file for Medicaid? Because that's what you hear a lot now is, well, we could, but a lot of them aren't even getting the reimbursements that they can get because it's so, I mean, it's state, we understand that, but there's so many things that you have to do, and they don't have the staff that can do all of those things or even get that education.
Well, right now,
trainings we sit in.
right now they can't bill us. We don't pay for it.
But I will say that, so there is a separate license. It's not a Medicaid certification, but there's a separate licensure for substance use disorders. So they have gone through, many of these providers have gone through that licensing, and then they've been able to enroll in qualified health plans. So they've been through the insurance process. They're currently billing insurance. So it shouldn't be that difficult for them, since they're already billing insurances, to then add Medicaid. And so when they enroll in Medicaid, we'll have a process by which they enroll that is similar, because we have to enroll all Medicaid providers. There's a certain standard we have to meet, and that's a federal requirement as well. There's federal and state requirements. But I think for those providers that are already enrolled in billing commercial insurance, this shouldn't be that much of a lift. And again, because we know it is a difficult process, we're making sure we're writing this into a grant to have training and technical assistance to hand hold them through that, because I know exactly what you're saying, Brittany, right? Even that, it is going to be, I really do believe it is going to be challenging for them to come into the Medicaid world. So we've learned enough to know that you can build the policies, but if you don't have that training and technical assistance. So we're working with AFMC, in fact, on adding them to the grant, because they already do a lot of training and technical assistance on our medical side. And so really getting them to just work in concert with those providers to get that done. So, and that's with a state opioid response grant that we have coming on. We apply for that. That application is due July 1. So I'll make sure that Jason is, once we get awarded that grant, because every state gets one, and we get that approved, we're just hoping that this is a SAMHSA grant, Substance Abuse and Mental Health Services Administration grant, making sure we're pushing them real hard on this of you've got to let us use some of this money to then our sustainability as Medicaid.
So what we're hoping is that you guys will see in the roadmap how we're trying to connect the funding we're trying to put out for construction and the rest of the programs we're trying to build, so that it starts fitting together. Because I think we have it in our mind how it all fits together, but we weren't very, very good about laying it out. So that's the goal of the roadmap, is to lay out that vision for where we're trying to get with our programs and our services, by looking at what the holes were in our continuums and what we really needed to focus on, because we only had so much money. So we had to make sure we were using it wisely. But what we're going to talk about today, and I think we have 20 minutes, is very quickly. Oh, no, Tommy, I swear. So we always do this. We need 3 hours, Jason Peterson. So what we're going to talk about very quickly the next 20 minutes. And we, again, this stuff is on that website. The PowerPoints are on the website, the one-pager. So we're talking about some prevention programs. So 2 weeks ago, we were standing here and we launched some prevention programs. Super exciting. We haven't launched prevention programs in what we believe to be at least 30 years, probably more than that. So the governor, one of her big initiatives is prevention, early intervention. It's one of our secretary's pillars of what she's trying to do as secretary of DHS. So we had a lot of backing and support. Our Medicaid director, Janet Mann's here. She is very supportive, and we get to finally move forward with some prevention. So we are talking about 4 pilots today at rapid speed, okay?
Yeah, and we can skip through, because this slide deck was done, you guys, because Children's Hospital said we want to do we want to get all of these stakeholders together, and we want to do a plan for behavioral health in our state, because that's one of our highest needs. And so I called Janet and said, hey, they think they're going to get a whole group of people together and talk about this, which is fine, but they need to understand Medicaid funds all of these services for children. It is a Medicaid program, and so unless we're at the table as Medicaid, y'all can talk about whatever plan y'all want to talk about, but it's really got to involve Medicaid. So the first couple of slides really is just to prove a point that how many...
Can you tell she's still mad about not being invited?
I was, y'all. No, because I was like, yeah, so, but I was like, so this
really
first couple of slides...
Rob's at home here, guys.
That's right.
5 slides.
All right, so we
Got
can...
uncomfortable.
So I think just the first couple of slides are just to show how many kids, right? Y'all, traditional Medicaid, 476,376 children are eligible for behavioral health services, and 34,000 of those children have a mental health issue and are in the past in 1626. So anyway, y'all, I don't have to
I was
belabor it.
standing right here, and I sat down. I went and sat down, right? Because it was like there was so many people in here, and I didn't see the deck in advance. I was like, oh, God. Okay.
I think it's like the next 3 or 4
We paid
slides
for
you can.
everything. All right,
yeah.
that's the gist.
We do. That's right.
right.
Y'all, $294 million spent on, and look, wait, no, just let me say this. This is commercial insurance, y'all, $28 million. So, okay, so I'm just proving this. This is how much Medicaid dollars.
Here's another one with the...
This is the number of people.
We take care of about 90,000. They take care of about 17,000. Okay, there it is again. We'll just keep moving on.
Sorry.
It's okay.
It's out of my system.
Let's get to the meat.
Yeah. So these are the services for behavioral health that we're paying for children. And so as you can see, this is once a child is identified with a need for a service. And so we pay for counseling. And then these are those home and community-based services that we were talking about, that we're doing some of that funding. So that service called residential community reintegration. So that's one of those we're going to pay for. And then our psychiatric hospital, so we're going to add substance use here. So this is our full continuum of services, and we pay for a lot of services for the past members in these home and community-based services. But what we do want to know, what we want to make sure that we're doing is anything that we can do to prevent children and youth from coming in here and going here and then going to residential and then going to institutional settings. So that's what we're talking about today, is all those prevention programs.
Yeah, and I think it's important we talk about this. So this bucket, this counseling bucket on the far left, this is what we call like our traditional Medicaid state plan services, meaning anyone who comes into Medicaid, right? So how many people do we have now, Janet? 800,000? Anyone who comes, does that sound right? Anyone, 850,000 people that come into Medicaid through any eligibility category are eligible for state plan Medicaid services. Now you have to meet criteria, you have to need it, the service, but it's available if you need it. And we call those traditional state plan services, and that's this bucket, all right? So when you look at this, really just keep in mind, this is what we're focused on. This entry point, not that you need more and we're going to move you into the past, or that or that you need more and you need to go inpatient out of hospital. We're trying to beef up right here, so anybody who comes in, we can make those available with 3 of these pilots we're going to talk about today.
So this kind of gives you that whole thing that we're looking at, but we're really focused today on this early identification and intervention, and a new service that we're going to put here in home and community-based service. And if you'll notice, not only is that in a home and community-based service, it's called family-centered treatment. It's a wonderful program. It's delivered in-home, and we'll talk about it a little bit more. But for SUD, they have a family-centered treatment recovery, which can focus on a parent who's having a substance use disorder. So launching those. And then we've got our statewide crisis hub services. Okay, so our Families in Transition pilot is our first prevention program. So what we found, and this is primarily from one of our sister divisions, the governor had a blue ribbon task force to end child abuse. And so in that blue ribbon task force, a couple of things were identified, but one thing was identified was that Children go through a transition, generally not during 9 to 5. Surprise, surprise. And so a lot of times children go into the custody of either us, DCFS, and they go into a temporary foster home before they land in a permanent foster home, or a lot of times family members can no longer care for the child for a number of different reasons. Sometimes it's because they've gone to SUD residential, sometimes it's because they've gotten ill, sometimes it's because they've been arrested and they're in jail. But children go to a family friend, they go to a grandparent, we see a lot, an aunt, an uncle, a family member. And so really during that time frame where children go into custody, they're upset. And they're struggling, and sometimes they have behavioral issues when they're struggling because they're scared and they've been through trauma. And so what we had been doing is sometimes the family member who received that child would call an ambulance or take them to a psychiatric hospital. And what we know is once that happens, generally, then you just go down that road and then you go to residential treatment, and it's just kind of a pipeline to institutional services. So really wanting to make sure that we support not only that child, because there's interventions that can be done with a child, but it's really about the stable adult in that child's home. And so this is creating a program by which a crisis line can be called, and people who are well-trained in trauma-informed treatment can be dispatched to support those families in transition. Also, an evaluation of that child will be done during that time frame. So not only are you providing that support to the family to make sure that they learn how to manage those behaviors and know how to manage all of those frightening things that are happening with that child, and their fear is to really think about if that child moves again to another place, of really having a good plan in place to follow them. So kind of a wraparound plan, so to speak. So that's our first pilot.
This pilot's going to take place, and that's on the website too. It's going to take place in 8 counties across the state. They were very meticulous on how they picked the counties. They were picked counties with high levels of resources, no resources. We have the juvenile judges in those counties involved, and are been notified and discussed the pilots with them. We're really focused on kids either going in, coming out of DYS custody, DCFS custody, and as the slide says, being discharged from like a psychiatric residential facility or some sort of residential treatment, just a high trauma period in their lives. So it is being designed right now and should launch very soon.
In that evaluation, okay, so y'all know this is, I'll probably have most questions here. On that, do we have a way to evaluate types of trauma? Like, one thing that we had to navigate whenever I was in that situation was my daughter was with my mom, who was a drug and alcohol counselor, so she was still going to school every single day. She still was, dressed. She doesn't look like she was going through any trauma. However, her mom was in prison. So for her, it was a traumatic period, but she was looked over for 3 years and not realized that she was going into a deep depression because she was still with a very good, stable family member. So I think that, in my opinion, one place that I look at that I would really like to see is we are some kind of way able to evaluate types of trauma for the children, because like, somebody really, their life may fall apart because they didn't get that Nike hoodie. Although we don't understand that, we don't understand why that's so traumatic for that kid, it is very real. Mm-hmm. And then you have kids that don't even have anything to eat at night that are like, just going through the motion. This is normal for them. They think every single person is like this.
Yeah. Well, so I think 2 things. Really on the evaluation, what we're really focused on, I would say, I wouldn't discount that we're not focused on trauma, because the services are going to be very trauma-based services, but the comprehensive assessment piece of this is because we keep processing, mapping children, and we're misdiagnosing them. So we're either missing that they have fetal alcohol syndrome, which happens on a large majority of our kids that we're mapping, or we're giving them a mental health diagnosis when they have an intellectual disability or learning disabilities, right? And so we're giving them the wrong types of services. Why we're so excited about this is that Partners for Inclusive Communities is doing this with a team of people with doctorate degrees that have done this line of work in small communities. So the staff that they brought to this project is very impressive. So and Karen Burnett, I don't know if y'all know her, she is the executive director of Partners. She runs our autism waiver. So we have a long-standing relationship with Karen and her team, but they are in there doing evidence-based on these types of comprehensive screens and assessments. So I have no doubt that this is going to turn out well, but we will definitely mention to her any type of trauma screening that they need to add to that, because I don't think that's really the focus at this second.
Yes, I think thinking about these, the focus of these is on the caregiver while the child is getting an evaluation, and then the child would be referred for treatment. So we've got the Medicaid treatment, because what we saw as our gap there was we've got Medicaid treatment. We're not getting the right children to the right treatment. And so the focus of all of these pilots is really on the family caregiver. Or if we'll go to the next one, it's on the teacher, right?
That is that one.
There, yeah, there it is.
It's up.
So again, the stable adult in the child's life, because what we saw was we discontinued some of the paraprofessional services for very young children. And we are getting calls from childcare centers, from kindergartners, and kids are being, again, kicked out of school at a very young age, expelled, and also, we see as young as 6 go into psychiatric hospitalization. I can't even imagine a 6-year-old being in a psychiatric hospitalization. So focus on the teacher in this case is really helping the teacher. One is to make sure we've got that good diagnosis, because we think the misdiagnosis is going on all the time, but really focus on those that are birth through 6th grade, of making sure that we get that teacher supported, particularly in a crisis situation.
We have a Medicaid service in place right now called behavioral assistance. You can get it if you're in the pass. You can't get it if you're just in the state plan. Regardless, it is a highly utilized service that goes from child to child to child. And we do have concerns that the parents don't even know that their child may be receiving it, nor is there any kind of communication loop to tell the parents what's going on. So the purpose of this is to highly engage the schools, right? Because they are a wonderful resource for us that we are not utilizing. Parents trust schools and the resource workers a lot more than they trust DHS, right? And so we have some really cool resource workers across the state in schools doing really great things to try to help parents, just kind of out of the goodness of their hearts. So trying to develop that team-based approach with a school employee in that team. And then it's going to have to resonate and go back to the house, right? So I think the way Partners is presenting this is the stabilization is going to happen at the school. It's going to be immediate. It's not going to be after it happens. Like they're setting up hotline numbers, which is kind of going to test our crisis model in some respects to see where we need to build out mobile crisis teams. So we're kind of using this to get some data for the next endeavor. But it's going to be live action, on-site assistance at schools that will stabilize, but the long term, they're going to have to engage the parents, because we know if we don't do something to help the parents in the house, then it's not going to change. So
they're already doing that in our court. So that's
right.
That's why that was confusing me, because everybody gets a FINS petition. If they get a FINS petition, of course, that's Family and Needed Services. They go before they have to come to court. And literally we have 4 peers now that are in the courtroom, and literally after they get done with DCFS, the judge says, now you need to go over there and talk to one of those peers about receiving services.
yeah, and I used to do FINS.
So I thought that was
No, and that was one of my first jobs at DHS. I was the FINS attorney. We don't want them to have to file a FINS.
That's right. This should be preventing
right?
that.
We don't need people to file a FINS to get services, right? But that's what we're doing.
Yeah, a lot.
This one overlaps both of them. You want to go into this? This is the screening. this
Yeah.
comprehensive screening and assessments.
Yeah, so we did a lot of look back at some of our 20-year-olds that had ended up in the state hospital or in our forensic system, and really tracking back through where we missed them. And so what we saw over and over is about age 11, they ended up in our state hospital and they were diagnosed with fetal alcohol syndrome. And we're just missing it. And I'll say that about my profession, which is mental health. If you walk in the door of a mental health provider, we're going to give you a mental health diagnosis and we're going to treat the mental health. We're not going to look at those other issues which could be impacting. So I think really important about this is making sure we're getting the right testing instead of waiting. Because I know you guys have probably heard, a lot of times parents will say, okay, I'm going to get a full battery of testing done, and then they get on the wait list for the Dentist Developmental Center.
Or this meeting.
This meeting. Mm-hmm.
The only two games in town, guys. So part of what Partners is trying to do is build this out, the provider network as well. And I'll tell you, I think we're a little hesitant of this because we don't really want our Medicaid providers who are going to provide the service to do the assessment and screening. Does that make sense? I mean, it's just, that's what's so beautiful about Dentist Developmental and this meeting center is they don't do hands-on service. So there's no inherent conflict for whatever they end up saying is wrong or diagnosing the child with. We do have some issues, with a behavioral health provider doing the assessment or a DD provider doing the assessment, because it falls right back to what Paula said, is usually you're going to assess for something or find something that you are licensed to provide and treat. So what we're trying to do is do some neutral parties here to expand outside of the UAMS network, which are those two.
My question is, when you mentioned Dentist Developmental Center, so we had went for my son for autism, just the test, but he was older. And so he was on the waiting list for so long, then all of a sudden they called and said, hey, we know your son is on the waiting list, but now he's aged out. We don't even cover it. So what do you do for those? And so we had to find someone, because usually if the child is not diagnosed by a certain age, they don't really test. So we had to really search and find for someone to be able to do those tests for him. So what are your options for families who have kids that are over the age? Because that's all we hear is, yes, Dentist Developmental or someplace in Conway, but no one tells us like, hey, but they stop at age 12 or age 11 or whatever age that is. So how do you help those families whose kids are older that may have missed that diagnosis in elementary and moved on to middle or high school, and you're trying to figure out what it is? Where do they go?
Well, we're not even doing it right now
Okay.
in elementary, right? So, I think the purpose of this pilot to start with that age bracket, right? Because it is prevention, early intervention. But I don't know that long term, if they build this network for us, that we will restrict it to that age limit, right? It's to hit that age limit to see how much good we can do to get in there early and do the right diagnosis early. But if we can build out this provider capacity, then I think it would behoove a lot of our Medicaid clients, right? There are other people that do it, that do this testing. It's just like that Medicaid will pay for, but it's like I think the two, the Smeeting and Dentist Developmental, are so well known, and they do kind of like the whole, like she's saying, the whole battery of testing, whereas the others only do certain types of testing for certain things. And we want the whole battery. Yeah. We're doing good. We got 4 minutes.
Okay, family-centered treatment pilot. So we have a pilot. So again, this theme, which is the child is the identified client. So in Medicaid, we can provide services to an identified child who's a Medicaid beneficiary, and we can provide services to an identified adult who's a Medicaid beneficiary. And for a lot of our children and youth, they may be a traditional Medicaid beneficiary, and we're going to provide services, and the adult in their life might be on in a qualified health plan. And so really thinking about this in a way that we can identify the child but provide these supports to the adults in their lives. So family-centered treatment is for children who've had some pretty extensive behavioral health issues. They have a behavioral health diagnosis. We know what's going on. And generally, they've been in an institution. So what we see is a lot of kids are identified during a crisis, and they go to a psychiatric hospital. They have a short-term stay. They go back home or to their foster home, and then it doesn't, whatever services, treatment is not enough in that setting. So outpatient counseling, some of the school-based services are just not enough. And then they end up going into a residential treatment facility, a psychiatric residential treatment facility, and they generally stay there for up to 6 months, sometimes a little longer. And then they're always going to go back to the community, and the community is not enough. And so what happens when they come out of psychiatric residential is the psychiatric residential provider says, okay, we're going to find somebody to manage your medications, and we're going to find somebody to provide you counseling services. And that's just not enough. They've come from an extraordinarily structured environment where they've had full-time staff working with them, and then they go back into the home, and the family is ready to receive them, but they don't have the supports they need. This is a very structured 6-month program that really helps families to learn to support that child that has either in danger of going into a psychiatric residential facility or that's come back and then reintegrating back into the community. So very important, and all the services are provided in the home. None of the service are in the community setting. And although family-centered treatment identifies the full family as their client, and that's how they're training, because we have some training going on with this, we're able to bill that to Medicaid under the child's Medicaid ID. So we just talked to them this morning. We were able to give some of the other ARP funding, Medicaid ARP funding to them to do pilot projects. And the pilot projects, we did $11 million. And so
$5 million in training, $11 million for providers to do the service.
So they are training in this. So they've been training, and they are going to announce awards of providers across the state. And it looks like, from what I can tell, they've covered 80% of the counties with this service. So our goal with this is to do this pilot, get the people staffed, up and running, and make sure that at the end of the pilot that we'll move that right into a Medicaid payable service. So we'll have the policy in some place that's Medicaid payable. This is just so exciting for me because we just know we've needed this for so long. And Family Centered Treatment Foundation is a wonderful partner in this, and people are really excited.
They are. And this program, once we pilot it, the plan is to make it permanent, but it'll be part of the PASS program, right? This is for that higher level of need, whereas the other 3 pilots we've gone through today, we do not want to have to diagnose children and get independent assessment and move them into the PASS. We believe that should be services available to a distinct group of children right when they come into care without having to go through any more hoops.
Oh, and it also includes a crisis service, right? So the same team that comes in and helps you learn how to integrate that child back into the family setting, if you have a crisis, and that happens a lot. So instead of picking up the phone and calling 911, families will be able to pick up the phone and call somebody who's been working with them that they know. And so we are paying for a 24/7 member of each and every team to be on call 24/7, so the family never has to call somebody that doesn't know them.
My question to this, I was whispering, when does this start?
I know.
And my second question, when it talks about family-centered treatment pilot to be at home, does it also cover like communications with the schools once they go back to school?
It will help the parent communicate with
the
school.
school.
So this is
Okay.
all about empowering the parent and the family to really support that child in those settings.
So like with maybe IEPs and 504s and maybe getting, okay. I might be interested in it.
Oh, goodness. That's what you were talking about.
Did it pop up?
Why did it do? Oh, God. Hold on. Well, it's gone. It was just on Statewide Crisis Hub, and it was weird. I don't know what happened. So we'll just move past it. But we've mentioned this at the beginning. So that slide, the font was all crazy and black in the background. This is just talking about what we're envisioning on the statewide crisis continuum. I mentioned we are all going to Arizona because they have a really cool model. the email to Arizona was like, Arkansas's coming to town. And they're like, great. How many of y'all? So we're all going to Arizona the second week of June, to look at their, I don't know what's happening. Okay. To look at their model,
There it is. It's
which is
showing right here.
which is a super cool model, but take it away.
Yeah, so what we know that we've done for crisis services is we've got money and policies and programs going out all over the place. Like for community mental health centers, we have funding that goes out, and each of our community mental health centers, we have 12 of them, have a call line. But really that call line is being responded to for non-Medicaid. So, and they'll respond, but it is really for those people that are uninsured. And then we had a line through UAMS, and then we have 911, and then we have 988. So we had all of these places that people could call, and and all of this funding that was going out, but it wasn't coordinated into one hub. And so what we know from other states is building one system, one hub, and have all of that money go into that hub and then go out. So it's not going to be just Medicaid funding. What we'll be doing is saying, okay, Blue Cross, this many people called the hub and had a dispatch, because our dispatch is for a mobile response, whether that is a co-responder with a law enforcement person, which is probably going to be a lot of it, or a co-responder with an ambulance, somebody that has that training and experience to really make sure that they can calm a situation in the community setting to keep somebody from being transported.
Some of the cool things about the Arizona, just based on preliminary conversations, which has been so helpful to us, of just because they've been running this for about 30 years there. And so they said, we really wish we set ours up before 988. So they have a 1-800 crisis number, and they have 988 coming into the hub. And they said, we encourage y'all to just use one number, right? Like, don't set up a second number. Like, let it all flow through 911 and 988 to y'all. Don't try to teach people another number to memorize, right? Which we totally agree with. Mm-hmm. And then yeah, it's so hard to eliminate a number once you get it out there. Mm-hmm. And then second, their contract makes their vendor who runs their hub get people insured. So that's part of their job that they're paying them to do. So not necessarily get them on Medicaid, right? It could be getting them on Medicaid. It could be getting them into our home. It could be getting them on Blue Cross Blue Shield.
So their primary premise is they take phone calls, and it is to address the crisis. And on the back end, then they worry about the payment and the coverage. Sorry. So what I was saying is the premise is the call comes in, the crisis is stabilized is the goal, and then it moves into the background of who is the payer. But they've been building this for 25 to 30 years. Mm-hmm. So we're going to try to take lessons learned and then jump up at least 10 years is the goal.
So our real goal next year is to have this started and going in 4 counties. So right now we have 4 crisis stabilization units across the state, which is not nearly enough, nor do they do exactly what we need. So part of the model is to go in and change how those crisis stabilization units work, because you guys know if we can't stabilize at home, we have to take people somewhere, and we don't want to take them to the emergency room. And so trying to get that model built out is one of our primary goals. So we want to start in the 4 counties that have them right now. Mm-hmm. And so that is what we're going to be putting out for a vendor to bid on is, hey, we need you to come build this from the ground up, set up the infrastructure, and start piloting it in these 4 counties. And then we're going to just continue to tweak and work and improve over the next several years.
And many other states have done this successfully, and all married that with 988. The other important component of this is not just the response to the crisis, is having some care coordination that's going to follow you from crisis all the way through till you get the treatment, right? You get in the right place for the treatment, because that's what we see all the time is, and I've got data coming in now of how many people go to an emergency room, have a hospital discharge, and then do not have follow-up treatment in the community. Because seriously, you've discharged somebody that was having a psychotic episode or having this being detoxed, and they're going to get it. They're going to be able to then call on their own and try to schedule their appointment and get themselves to the appointment and all of those things. It'd be just so complicated just to do from ground. So a big key component of this is the following of people beyond the crisis.
We almost did it.
You did great.
Okay.
So some of you were able to ask some questions, not all of you. Maybe some of you still have some questions. Paula and Melissa covered a lot, $30 million in grants, 4 pilot programs, a lot of information there. So if you took some notes and you have some questions, let's take 10 minutes if necessary and give you an opportunity to ask those.
Hello. I want to go back to slide 11 about the CSAC pilot. And that kind of caught my attention because I'm excited about that. Because personally, my 3-year-old, we experienced her like falling through the cracks after 2 unsuccessful attempts of placing her in a school, in an early education school. Even though she had been diagnosed with developmental delays and a speech disorder, which should have brought up a flag to her primary care doctor, it did not. She would say, oh, she's just stubborn and silly. When I would bring up my concerns, I wanted to know, like, well, why does she have these delays? And I would like to know, like, what is the collaboration going to look like? Because we have another little girl that we go on play dates that's also 3 years old, which I don't have the heart to tell her mom that I think she's also in the spectrum, but I know she is because she has some of the same characteristics that my daughter has. But this little girl is about to start school, and I already know like what's going to happen whenever they give her those assessments based on their age range. They give them assessments every 6 months, and that's how we caught it. But the other families that don't have their kiddos in school and have brought up concerns to the doctors, you know, is there a way where they're going to have like a screening if the kiddos already display, you know, some of like the telltale signs? Like, are they going to listen to the parents when they show up and say, you know, is there a screening that we can do to get further testing? Because it took us years and years to get that figured out.
So outside of this, Arkansas Medicaid, starting this past January, is paying primary care providers to do developmental screens. We've never paid for that before. So like when I took my kids through private insurance through the state, they did an ages and stages on my boys starting early, right? And they could see if they weren't meeting their milestones, right? Which did lead me to further testing. Yeah. But so we're really right now doing a big, and I'll say Tommy's in the back of the room, leading a big PCP campaign in education awareness with them in conjunction with AFMC. To train PCPs on the importance of doing developmental screens as recommended by the American Academy of Pediatrics. So, and we will pay for those screens. And in order to either further reinforce it, if you want to go to an early intervention day treatment program that Medicaid pays for, you must have a screen from your PCP. So just to try to kind of force everybody to get into this mindset of how important it is. And at the same time we launched that in January, Paula launched depression screens. So we had not been paying for depression screens on children either. So now, and my kids have been getting depression screens through my private insurance, right? Once they hit, I think, 12 or 13, they started giving them to them. But now Medicaid will pay for our kids to get depression screens. And in conjunction with that, you are now paying and allowing therapists to be in the PCP offices. That's a new change as well as too. Because the goal that Paula wanted was them to say, oh my gosh, something's wrong with this depression screen, and walk them next door immediately, right, to see a therapist that's housed in the pediatrician's office or the PCP's office.
And not only did you do the depression anxiety screens, but we also, back to the parent piece of this, is we're allowing under the child's Medicaid ID for the parent who brings that child to the clinic to be screened as well and bill Medicaid under that child's Medicaid
So
ID.
really trying to get mothers, right, at that point to see, because y'all know, y'all that had kids, y'all know, like You need that screen, right? Especially when you just have had children.
And then I also wanted to ask about the behavioral aspect, because usually some neurodevelopmental diagnoses come with behavioral issues, and UAMS is doing like a study or like a behavioral, like a parenting class for parents and kiddos, and me and my daughter are going to participate in that. Is that something that maybe that is going to be available, or is the behavioral service just going to be for like extreme cases?
No, I think that those are exactly the kinds of supports we want to do. So we do have, and we need to make sure we get this on the books because Nikki Edge emailed us. So Nikki is with UAMS, Dr. Edge, and so she's been doing a lot of this work. So she's been doing work for a long time in child care centers, but also this, because that's one of the things we want to see is, you know, while Medicaid can pay for a lot of this, there are other things that are going on that if we don't integrate with other people like UMS. I'm glad you brought that up.
We have
So
that
can-
scheduled.
Yeah, do we
We're
have
meeting.
it scheduled?
Yeah, we're
Good,
meeting.
but we'll ask about that. That's great because, yeah, it's not just about the a diagnosis and treatment. It's about all those other supports. That's wonderful. Is that Northwest, UMS Northwest?
UAMS, it's actually at the psychological clinic.
Okay.
It's at, actually at the University of Arkansas campus.
Nice. Okay.
Yes.
Cool. Thank you.
Great.
Any other questions from the members? I haven't gotten any texted in, so any in the present who are present that have any questions? If not, Paula, Melissa, thank you very much. A lot of
y'all.
great information. We're going to break for lunch. Yes. We're going to break for lunch for a half an hour, and then we will reconvene after lunch. Well, welcome back for the second half of the Medicaid Client Voice Council meeting. We've got a couple items on the agenda before we move to our open discussion period, which we always close with. You should have all gotten in your emails a report that I sent you. Does anyone recall how many pages that report is? I think it was 132 maybe. It's a lot. It's a lot. Yeah, it's a lot. I don't expect that any of you digested it in full, but hopefully in parts, where the parts that most interested you that you may have some questions about, because we have just the person to answer those questions for you today. Deputy Director of Health and State Medicaid Director Janet Mann is here, and Janet, were you going to answer, or was it? Because I don't see Elizabeth.
Yeah, Elizabeth is out.
Right. Right.
I can try to answer some questions.
Okay. Well, we'll make it short and sweet. So if you looked at that report and have some questions, if Janet can't answer them, I will record them and we'll get an answer for you. So this is on sustainability review. Yes. Yes. So I'm going to bring you a microphone, Janet, and I'll keep the other one. Not really a presentation with this.
So, I welcome the questions and actually would prefer to get them in writing so that we can respond to them in writing and put them as part of public comment, which we are doing over a course of 90 days. So, I can make sure, Jason, I can make sure you have that link to send to everybody so they have a copy of the report if
No, they
haven't
do.
already.
They've
Okay,
all
good.
they were all sent the report. So
Excellent. Okay. I'll-
so
I'll-
does anyone have any questions about the sustainability report? Yes. Brandy does.
I printed out only 4 pages
Oh, of the 120 something? Yeah.
and whatever. So,
Can I look over your shoulder?
so the demographic that I represent is our aging communities.
Okay.
Okay. So I see that there is there's a very big deficit in facilities as far as assisted living facilities. So we've got an aging community that is not really safe enough to live at home, but does not qualify medically for long-term care in a skilled nursing facility. So they're in that gray area. I'm finding that we've got fewer and fewer assisted living facilities that are accepting Medicaid. We used to have 1 or 2 in every community, and now I'm finding that they're, for whatever reason, no longer accepting Medicaid. Hot Springs, Benton, Bryant, Those are the primary areas that I'm most familiar with. So I was reading over what y'all had as far as your growth in aging populations and what your expenditures were and what you were projecting and so on and so forth. So what will you do, or what is going to be put into place when you're offering these waivers for assisted living, but there's not a facility that will accept that waiver? As far as home and community-based services, we're finding the same thing. I have patients that I have tried to apply for, that there's not an assisted living facility for them to go to, so they're going to try to stay at home and age in place. So we're going to try to get home and community-based services for that. But then when they go through the assessment process, they qualify for maybe an hour a week. That's not doing anyone any good. So, I just don't think that the allotments that you had here were realistic in those two categories.
Allotment of services or money?
Expenditures are, and how much they've increased and how much they're going to talking about what the expenditures are and how much they've increased and how much they're going to continue to increase. I don't think you were generous enough in those two, in home and community-based services and assisted living facilities.
So I wouldn't disagree with you. So I do think one of the challenges with Medicaid is fee-for-service, which is utilization-based and what you qualify. The waivers are outside of fee-for-service, and you have to qualify for fee-for-service, then qualify for the waiver. I think one of the challenges the state is going to have to address in the next couple of years very soon is the aging population. I think in the next 10 years, by the end of the next 10 years, our population that is over 60 will outnumber our population that is under 60. That's a national statistic. And so it would be very applicable in the state of Arkansas. Knowing all of that and knowing that age blind and disabled is how I refer to it, because it's either children or it's age blind and disabled in the Medicaid population. That is our largest growing number of beneficiaries. It's also our most expensive. It's the 80-20 rule. You spend 80% of your dollars on about 20% of the population in that area, primarily with skilled nursing facilities that are very expensive. So the question comes down to, how do we expand those services and be conscious of our budget and be conscious of current providers, that our intent is not to hurt providers. Our intent is to really grow. We've got a workforce issue, I think, with some of the pilots we've identified. So it's lots of issues. We've got workforce issues, we've got aging population, and we have budget concerns. There's always the three areas that we have to consider. So a couple of the things that we're looking at, working with the different provider associations and different entities, is really looking at how to equalize the front door. When I say equalize the front door, we've all talked about this, but when someone applies for services or they're leaving the hospital and they're in that gray area, how do they have the option to choose? Go home with the appropriate care, or go to the nursing home if that is what's needed. And it's very hard to build that, because you've got to have your workforce, which I've already struggled with. I have to have the service providers in place that has that workforce, and then I have to have the dollars to pay for it. So it's very heavily on all of our minds of what we're going to do. But there is no clear-cut answer.
Okay.
I have kind of a follow-up to that one, and not just automatically, not to be rude about anything. However, how much longer as a state is Arkansas going to allow our citizens to be untreated or not socially deterred, stable, for lack of better words, with using an excuse as the workforce? Now, I know that y'all can't actually make the workers, but what does it look like to go see maybe how some of these services can go over into other workforces that there are people available in? Because where we're at now is a lot of dollars. We're talking billions are invested in things in the state, and we're not being able to utilize it, and the people in the community are not getting the utilization because of a workforce issue or a lack of having someone there?
So that's above my pay grade. I mean, that's going to be a legislative question. I'm not trying to punt. I mean, but there's a workforce cabinet that is working on trying to grow the workforce in the state of Arkansas. That involves, I think, 6 secretaries in the legislature to work on those business development and those workforce training and growing that. I'm not a member of that. I just know that it exists. Cost and price always plays into it, and it's a legislative issue. They appropriate and fund us, and it's gonna be an interesting couple of years.
Oh, yeah, that's what's going to be the next question. So how is DHS going to approach the legislation with that? Because if we know workforce is a problem, why did we close down the Department of Workforce and combine it with another entity? And so now we have no county offices.
So workforce services, to my understanding, became part of commerce under transformation. I'm not quite sure at the exact date of when that happened. I don't know if anybody else does. As opposed to closing their offices, you would have to ask them. But it was based, I think there was some conversation around how many of those offices are used every day. So I don't think they closed them just to close them. But I don't have that data.
Any other questions from the sustainability review?
First, who wrote that? It was so nice.
The report?
Yes, it was so.
It was in conjunction with the team at DHS, and then Guidehouse is a contractor.
I got it.
And so we worked on it internally and with a contractor. There's a second piece coming that will be coming from Milliman on hospitals.
Okay.
And it's being approached the same way with a combination of staff and contractors.
As far as families or caregivers or kids in behavioral health, and I know I saw a piece in there that talked about, and I could have asked for listening, but and they talked about different ways of offering assistance for the caregivers that are with the kids. How do we go about doing that? So like one thing that I was thinking about is when you have kids that are going through in the behavioral health field and they're going to residential care, like is there places where the caregivers can go for like therapy services for themselves or getting themselves back together to be able to be prepared for when those kids do come home?
So someone's going to help me write this down. We do have some respite grants for our various programs and our caregivers. Most recently, the Alzheimer's respite grant has been in the news. There is still money left, just for the record. And so I think we can get you some details. But there are some respite grants for caretakers. I don't know all the specifics, and I don't want to mislead you. Did you want to say something?
Just that, as we talk about it, so making sure, so Medicaid can pay for a child as the beneficiary. So when a child has a behavioral health disorder and they go to a residential treatment facility, then Medicaid is paying for those services.
Right.
And so we've really struggled with then, can you start providing services for the families prior to that child coming out to get them prepared? So it's really difficult on Medicaid, but because we're all DHS, sometimes we can do things like Medicaid can pay for that, but then I can use grant fundings because at OSAM, I'm not just over the Medicaid piece of this, I'm also over the block grant and state general revenue pieces, is looking to see how we can use money to, if there's any money that we can free up to pay for those other services, so you can't, because you can't double bill.
Bill.
Yeah.
Yes, because one of the things that I'm finding out, my son's been in residential care before, and I've liked them, but where he is now, we have Wednesday family services, and what I'm liking about the therapist is he's actually telling me, like, this is something that you can do at home. This is something that will be helpful if you have this. And I'm like, okay, that's good, but he can't sit with me for, it's like he's giving me snippets of things. But okay, I was like, well, how do I reach that? How do I get that? You know, how can I prepare? And of course, my son may be, you know, he'll go get him after we've had our conversation. He may go get him and I'll sit with him for like 15 minutes or so. But then I was like, gosh, how am I able to implement that before he gets home services for the caregivers? What are some things that thinking when I was reading about some of the services for the caregivers, what are some things that, you know, things that we can do or places that we can go to be able to get more help to be able to prepare for your child when they come home? Because one thing that my son has always told me, and I've heard from other kids, you know, and parents will look at me and go, for some reason, they really like it in those places, you know, and I go, well, my son tells me, well, the reason that we like it in those places because like towards the end when it's time to come home, sometimes he may do something and they be like, he act like he doesn't want to go, you know. And so what he tells me is that when they're in those places with kids who have the same issues that they have. And so no one's judging them. No one's saying you don't fit in or no one's saying any of those. So they feel comfort in those places around the therapists and the nurses and the other people that may have the same issues. And when it's hard to come home because you're trying to fit yourself back into a society that may not
Be as accepting.
that's being
I'll say it.
accepting. Yes, that's accepting as far as when you come home, though, you know, we're preparing him for home, but your other family members may not know. When you go back to school and you have to face 8 classrooms, 8 different teachers, 20-some kids in each classroom when you're trying to do all of those things, especially if you're coming back in the middle of a school year and you didn't get to do the August preparation. So that's why I'm asking.
So, and I think you added a twist to the question that I didn't appropriately answer. So, respite for the caregivers to have a break, but I think we need to add to that for some assistance or training as they do transition back to the appropriate setting.
Yes, that's
so
what
I just wanted to acknowledge that, but I apologize that I have to go.
Okay.
We didn't know Elizabeth was going to be out. She had a family emergency. So if you have anything else in writing or questions, if y'all can work on that.
Janet, one yes or no question from one of our online viewers. Is respite coverage covered for Medicaid waiver clients?
It depends on which waiver, I think.
Depends on the waiver?
I think so, but we can get some clarity.
Okay. Erica has submitted a couple questions that I'll
Okay.
share with you guys in writing. And any other questions that you have for Elizabeth or Janet, you can submit to me in writing, council members, and I will forward them on to the people who can best answer them.
Okay.
Thank you
Thank y'all.
for sticking around, Janet. We appreciate it. All right. So Mary Franklin's here. She is our final presenter today before we move to an open discussion, open Q&A. Some of you, I know that Brandy did, Brittany did, participated in the Access Arkansas portal demo that we held earlier this month. It was an opportunity to just go online with some of our people and with your questions and just kind of fool around with the Access Arkansas portal, ask your questions. Some questions were born out of that, some suggestions. Mary's going to come up and kind of summarize how things went, and maybe some of you have some issues or questions that you've thought of or experienced since then. So for those of you who didn't participate, this is just all about using the DHS Access Arkansas portal, and I think that through this conversation, you'll probably hear some things and learn some things about it even if you weren't online that day. Mary?
Good afternoon, everyone. And thank you to those who were able to attend the demo. We at DHS found it very helpful to do that demo and take our time and go through it and answer questions, and we learned things. So I also want to thank my team that prepared that demo and hosted it for us and navigated us through. What we did is we demoed the Access Arkansas Citizen Portal. So this is the portal that our clients can use to apply for benefits. They can screen themselves to see if, they might be eligible before they apply. And then once they have a case, they can also see what the status is. They can set up alerts, email alerts, text alerts. They can opt into electronic notices or keep paper notices. They can do renewals, changes, online, and they can also upload documents. So there are a lot of things that you can do, but from time to time, it's just a good idea to let a group look at it and give you feedback on what's going on. So I do want to let you know one thing. We had this change already in the works before the demo, and that is you can create an account. Anybody can create an account. You don't have to even apply for services to create an account on Access Arkansas. But then you have to link your case to your account to be able to see anything, right? Because I couldn't just go in there and pull up anybody's case. I only need to be able to pull up my own information. But if you applied online, you could also see the status of your application. But if you turned in a paper application, you couldn't out of the house, and it was actually a case registered in the system on our side of the house, and it was actually a case. So one of the changes we're making is to enable you to actually link to an application before it becomes a case, and that change is going to be implemented in the system on the portal in November. And there's another change in the works that is not on the roadmap yet. I mean, it's not actually slotted into when we know it's going to be implemented on this date. And that is, we had gotten some feedback about needing to be able to see more about the status, because like right now you can see if it's pending or if it is closed or open, approved or denied, but you don't see the nuances like it's pending with a caseworker, or it's pending because we're waiting on information to be turned in, or it's pending because the supervisor needs to review it. So we're going to do another enhancement. I think they call it like the pizza delivery, thing. So you can see which step it's in more detail. And then one of the big things that we learned that we did not realize was a problem, because when we designed the citizen portal, we did not think about people who might be an authorized representative for more than one client. And what we learned is that if you are an authorized representative for more than one client and you've linked to their cases because you're their authorized representative, that there's no way to set alerts up for multiple clients as a single authorized representative. So I'm sure that was creating a lot of frustration. But that is something that we now know and is going to go on our roadmap to make an improvement, so that if you do happen to be the authorized representative of more than one client, you can set those alerts. I don't want to do all the talking here because we do have 2 members of the council who were in the demo, but basically we got good feedback and we learned that, that particular pain point, but happy to take any questions or listen to others.
Yeah, let me give the microphone to Brittany and Brandy, and they can just share what they learned or what they thought of the demo.
Actually, I'm glad y'all did the demo, so thank you for taking the time and breaking that down, because that's been one of the consistent issues that I've known is we have something and it's there and it's very, very, very useful by step, whether you're doing it as community. So for me, learning how to navigate it, taking step by step, whether you're doing it as a community partner, so the way that you can assist people, and then also how to do your own case if you are still receiving services and to link it back. But then just mainly being able to do like the community partnership and being able to be that liaison or contact person, I think that that's going to make a big difference in people that need to receive services that are like homeless or don't have anywhere to actually go, because they can use a mail address to somewhere that they can go in and check into. So that was a very positive.
Thank you.
I would second everything she said. It was a very helpful demonstration for me. I was able to go back to about a dozen different skilled nursing facilities to talk to the business office managers after that demonstration to explain what we had kind of gone through, what improvements we suggested, and that there was hope on the horizon for them to be able to, because most of, I would say all of them, don't don't use the portal. They're still submitting all of their applications via fax, and it's a very tiresome process for them because, as you well know, when you're submitting the supporting documentation, you can't submit 150 pieces of paper in one fax. It's multiple faxes, and then they're wondering, did it get received? Did it not get received? Did it jam? Did it this? Did it that? So I think that would be very helpful. And like you said, linking the cases, especially for me, with 25 different elderly patients that depend on me to do their renewals, because as you well know, notice of action and the U.S. Postal Service doesn't work at all. And so that would be most helpful, to be able to move to an electronic format and be able to submit applications through there, as well as receive the NOAs especially. I think will be instrumental in streamlining that whole process and communication, because it's really hard to communicate with with the caseworkers sometimes. So if you've got a direct link through them, especially being able to upload things and that they can see immediately without you having to fax it in or email it into them and then being attached to the case, that's going to be huge.
Thank you. And one of the things we also showed is where you can go as a client to see your notices. Like, even if you get them mailed to you through the regular mail, there will be a history in your account of everything we've sent you from the eligibility system. So that is another thing that we showed. And we're going to continue to do, to let people know about the online functions that are available. Send those to us, because we are, taking a look at things. Any other pain points, please feel free to send those to us, because we are, taking a look at things, and we know we're going to be making some improvements. But happy to know if there are any others. One of the other things we also showed on our DHS website, there is a client toolkit and a community partner toolkit, and some of the information overlaps. But our amazing comms team at DHS, as we were building this system, created a series of videos about each step in the process, like how to create an account, how to link your account, how to upload a document. I mean, I think there's about 14 different videos, and none of them are like a 30-minute commitment. They're all pretty short, and you can watch them as many times as you want if you're stuck, at a particular point. So we also showed where those were, and again, we're very happy to do the demo and very happy for the feedback. So any other ideas you have, just send them our way. It's mary.franklin@dhs.arkansas.gov.
I saw a lot of heads nodding when you talked about the pizza progress.
Yeah.
Yeah.
If I go to Sonic, that's what we're thinking.
In the process. Yeah, that's nice. Yeah.
Something like that is what we're thinking.
For some of us procrastinators, I like to wait till the last minute to turn our paperwork in. I remember our last meeting, I was not as concerned about the navigation, because I can figure that part out. But I remember we talked about just if our application was received, that's all we wanted to know. And you said there was some help buttons, like if you hovered over something, like it would tell you, or it would pop up a message or something like that. So is a tracker going to take place of that? Like, is it going to show you like it has been received, or
no?
Just to know if you submitted it correctly.
The help information and access to those help tools will still be there. This is just like if you log into your account and you have something pending, what we envision is you'd be able to see the actual status. If
Okay.
it takes 5 steps to get from start to finish,
Okay.
where are we at in that process?
But let's
to give you a
say-
little more information.
Well, since the process changed and it'll automatically cancel your application if you don't submit it by the deadline, how fast is that tracker? Like, is it gonna be like if you place a pizza order, is it gonna pop up and like, do I need to go and also in process? Or how would we know, like, do I need to go and also take it in person and make sure that it's time stamped?
So, And what you are correct. So if once we have taken the application, logged it, or we call it registering it, we've registered it. So that's how we track how long we need to, when we need to get it completed. A caseworker goes, the next thing that happens is a caseworker makes sure all the data is filled in the system, determines whether we need any more information, and then the system will send a notice. It'll go by mail unless someone has asked us, specifically opted into electronic notices. It'll go by mail, but if you have an account on Access Arkansas, it'll also go into your account. So you could see it if you logged in while you're even waiting for it in the mail. Okay. But the notice will tell you when the information is due back. Yeah. And then we will automatically deny the application or close the case if it's information we had to have for eligibility purposes and we don't get it back. So what we envision is the tracker would show you each time it passes a stage, right? So if you logged in and it said, waiting on information from the client, or whatever we come up with that makes sense as far as how to explain where it's at, then you can, if you can see that notice, you can go to see the notice and you'll know exactly what we asked for and when it's due if you don't have the paper copy in your hands already. So you will be able to know, and maybe that's that's something I can take back, is if it is, if it's under a deadline, like maybe to have that indication there too, so you could see that as part of the tracker.
Yes, that would be nice, because unless somebody actually looks at it, they may not get to it until after the deadline, and then the system is automatically going to close your case. So in that case, me knowing that, I'm going to revert to, if I wait till the last day, I'm still going to go in person and take it, just to make sure it gets time stamped.
And you can do that. We are glad everyone is not service ability that we have online with Access Arkansas, but we know that everyone is not comfortable using an online system to do that, to do those things. So we have county offices. You can go in person. You can mail things to us at the county offices. You can email. You can fax. So there's multiple ways that people can communicate with us and provide information that we need. And but I will say, if you have an account online and you upload a document, it will tell you and show right there when it was uploaded, what was uploaded. So and you will have confirmation right there on the screen. Right there on the screen. So whatever method works for our clients, that's the method we want them to use.
Any other questions? All right, thank you, Mary. And thank you for those who participated in the portal demo. That was actually your guys' idea, so it was a good idea, and both sides, I think, benefited from that. We have our open question part of the meeting. Now, let me preface this by saying a lot of our institutional knowledge has either left or is not in the room right now. We have Mary, we have Paula, and if you ask a question that neither one of them can answer, I will record your question and I will get an answer. They know everything, but they know a lot, so I'll get back to you. So they know a lot. They don't know everything, but they know a lot. So feel free to ask whatever you want, realizing that we might not have an answer immediately. So any open questions from any of the council members? And let me grab my phone in case I'm being texted. Okay, so Erica did text a question about the portal. She says she loves the Access portal, but my question is, when tech support tells you that they can't help you with getting into the portal anymore, who else can they turn to?
County office. Our staff in the county office should be able to help you.
Okay. All right. And I know Erica is in a wheelchair, but all county offices are wheelchair accessible. So she says, thank you. Thank you, Mary. All right. Any open-ended questions? If not, let me say that last year, our July meeting was held virtually. It's the only meeting we had virtually all year. That's due to schedules, both of your schedules, summer schedules, and DHS leadership schedules. We will probably do that again unless I hear any strenuous objection to that plan. It seemed to work last year. We had good participation for our online meeting. So is everyone cool with that? If we do that, because I'm pretty sure the DHS leadership will be in favor of that. So as long as the council members are as well, we'll probably do that. Don't have an agenda yet. As always, if you have ideas for our July agenda, let me know. Last year it was pretty simple. It was the open Q&A, and I think we did a COVID update, and that was where we were in COVID at that time. I think that's all we did. So it'll probably be a shorter meeting. If you do attend online and participate, you're still eligible for the stipend that comes with the meeting. Obviously, there won't be any mileage or transportation reimbursement, but you'd still get your stipend if you attend the July meeting. So with that, yes?
For the next meeting,
Yes.
would it be possible for us to do I'd really like to learn more about the home and community-based services, because that's an area that's not very well described on the websites. There's a lot of, where you can, there's adult daycare centers, there's, different things, but it doesn't really go in depth into how do you qualify, who qualifies, and what the criteria is. Because when I have tried to get patients qualified, like I said before, they don't get enough for it to amount to the effort that was put forth to get the waiver to begin with.
Let me get a nod from Gavin. Guidehouse was working on those one-pagers. Was the community health...
Those are the one-pagers. I think we brought a couple...
They were working on for us?
Those are the one-pagers. I think we brought a couple of them to a meeting, maybe the last meeting or the one before that. Those are nearing completion, so I do think it would be good to have an agenda item for you all, maybe to get them all in advance and to review them and then to ask questions. I believe those will be ready. That would be the only question, is if it's in time for the next meeting, but I think they will be.
So what I'm hearing is, if not July, definitely the meeting after that, we can definitely have an agenda item just for that. Yes, oh, I'm sorry. Oh.
I just made a note here, if you want to put it on the agenda. My name's Deborah Inman, and I'm with the Department of Aging. So that's, I think what you're asking is for basically a rundown on how somebody qualifies for the home and community-based services.
Of what services are actually available to them, and like the approximate number of hours or services that they can receive at home, because a lot of times it's difficult to evaluate whether somebody can stay at home.
Yes.
And whether you would offer enough services for
Right.
them to be able to stay at home.
Yes, I think we can put that on the agenda for the next meeting, and I'll make sure somebody from Aging, either myself or one of my colleagues, can cover that topic for sure.
All right, and if anybody has any other agenda item ideas, we do have our meeting in June. DHS leadership has a meeting in June, mid-June, for the mid-July meeting. So just, as always, share with me via text or email your ideas for agenda items, and we will discuss those at our agenda planning meeting. So, yes, Angela.
I had a follow-up question for Paula about the pilot programs, the CSAC. I know you said that the PCPs are going to get funding to administer some assessments. Are they also going to be capacitated? Because I know that a lot of times when I walk into my PCP's office, I already have a prognosis for my daughter, and I already have what referrals that I need. And she usually tells me, like, if you need any referral, just ask me. So meaning, like, she's good about referring out because she really doesn't specialize in any particular area. And because I feel like this is a diagnosis that right now, dentist developmental and Schmeeding, which are specialists and have had additional training in these areas, are they going to get additional training? Is that what it means on the second bullet, that they're going to get training also for this?
So when the PCPs do the screening, so they would be able to do the screening at a well visit generally, and so in our PCP offices, we have something called patient-centered medical homes. And patient-centered medical homes doing more of that. They're doing, and this is a Medicaid program, that they are doing more of that case management, care coordination kind of function. And so through AFMC, we do a lot of training with primary care physicians. And so one of the things that we would do is to make sure that they understand how to refer out for those thorough assessments, since they're going to be doing the screening. So we would have that ability to do that, and it sounds like that we need to do some beef up of our training around the community-based referral sources. And I know that when we changed it a bit, that some of our policies around use of psychologists to do some of these assessments, that PCPs were relying heavily on psychologists, and so we need to get out there. And so I need to make I'm looking around to see who from AFMC is sitting in here, because AFMC does our training.
Because I'm thinking at the Children's Hospital, there's a lot of specialized nurses that work in like different specialties that kind of do like this kind of like preparation for the doctor, like when you go into your visit. They kind of do this kind of things, but for that field, I don't think there is any sort of like RN that, you know.
Yeah, it is. It's a pretty standard screening tool.
Okay.
And so we have somebody that we work with a lot. Her name is Anna Strong, and she is, the pediatricians are all organized into a group called the American Association of Pediatric Physicians, and there's an Arkansas chapter. So they were in large part part of the group that really pushed to have the screenings reimbursed. And so I think what you'll see is that when the screenings get reimbursed, which weren't before, then they would have somebody that would be able to administer those during the time frame that you're waiting on the doctor. And so, those screenings should either be able to be done by like a care coordinator kind of person.
I know for me, when we went into my daughter's
As they're doing blood pressure and all that.
Because I know for me, when we went into my daughter's official evaluation, which was a day-long evaluation of testing, I had to prepare myself to know kind of what things to point out, what to look for, and what to tell them as far as, you know, what I thought were things that contributed to the diagnosis. So I went and I just like read books about, you know, that I thought would help me. But I had to know like a lot of the things to look out for. So I felt like I had, as a parent, that I needed to know like what to ask also and what to say. So like you don't know what you don't know. So I felt like if I wasn't prepared, I wasn't gonna be able to get my daughter the best diagnosis or the appropriate diagnosis. So I feel like the parents should also be educated and participating in, because part of that is the questions that are asked to the parents. Like half of that, you know, has a lot of weight in the diagnosis as far as like how the children acts like in their natural behavior, which is at home. And a lot of that, like you have to know a lot of behavioral stuff and know exactly what to say and what to like know exactly what to look out for.
Yeah, and that is something that we can talk to AFMC about, is not only making sure that the doctors know and understand that they're going to get paid for those screens, that they do the screens, but is there any sort of parent education? So if the child has a screening that indicates the need for testing, you know, is giving the parent some information to prepare them for the testing environment. Okay, good point. Thank you. Take that back to them.
All right. Any other questions? All right. Well, I appreciate each of your attendance today and your participation. This concludes the May meeting of the Medicaid Client Voice Council. We will be in touch about the July meeting. Thanks.